I'd like to introduce Dr. Marc Singer. Dr. Marc Singer is a professor of surgery within the Division of Colon and Rectal Surgery at Loyola University Medical Center. He received his undergraduate degree from Washington University in St. Louis and medical degree from the University of Illinois at Chicago College of Medicine. He remained at the University of Illinois for general surgery residency. During that time, Dr. Singer entered into a research fellowship under the mentorship of Doctors Harand Abkarian and Jose Cintron. After completing general surgery training in 2005, he returned to Washington University in order to complete colon and rectal surgery fellowship at Barnes Hospital under the direction of Dr. James Fleshman. Dr. Singer has practiced colon and rectal surgery in Chicago since 2006 at the University of Illinois North Shore University Health System, Rush University Medical Center, and most recently at Loyola University Medical Center since 2017. He serves as the medical director of the outpatient surgical clinic and the regional director of the Enhanced Recovery Program for the Loyola University Health System. He is also the managing director of the Chicago Colorectal Symposium and serves as the executive director of the Chicago Society of Colon and Rectal Surgeons. We are excited to welcome Dr. Singer on his speaking to us today about the surgical care of Jehovah's Witnesses.
Good evening. Thanks very much, Ivy. I appreciate the introduction. Um, Tonight, we're going to talk a bit about caring for Jehovah's Witnesses, which may be something that some of you are familiar with, maybe something some of you have never done. It also, I realize, may seem like sort of a weird topic, but I think an important one when faced with patients in difficult situations. And so helpful to be familiar with some of the strategies that we use so that when you are faced with these rare occasions, you already be familiar and know what to do. So let's get into it. I do have a couple of disclosures. I work for some of the usual companies, and I will be speaking about some of their products. I'll start with some other disclosures. I have to admit I am not an expert on religion. I'm not a formally trained ethicist, and I'm not a Jehovah's Witness. I'm really just a Jewish guy working at a Jesuit hospital who has a lot of Jehovah's Witnesses in his practice. And based on that experience, I do want to talk about caring for these folks. What I'm not going to do tonight is an extensive data review, which I think you will appreciate, in part because the data is largely terrible. Most of the publications include very small numbers. Here you see one citation out of Spain, and it seems perfect, right? Colon cancer surgery and JWs, that's exactly what we would care about. But this review was published with a total of 16 patients in it, so clearly not very helpful. Also, a lot of literature suffers significant selection biases in that people love to publish, I did this number of cases and they all did great, or I did these cases in Jehovah's Witnesses and they all did terrible. And you can find whatever you're hoping to prove. And a lot of the publications suffer from what I sort of consider a race to the bottom. I did a successful laparotomy in a patient with a hemoglobin of 10 or 5 or 3 or 2. And you can find those kind of case reports, but I just don't think that that's helpful because as hopefully you'll glean from this talk, the better strategy is to avoid doing those kinds of cases and optimize the patients as best you can. And successfully do your cases without the need for blood transfusion. And just to set a little bit of perspective, although the numbers are sometimes rare, it kind of leaves you wondering, well, how rare is this? What's the issue anyway for giving patients blood transfusions during colon and rectal surgery? And we do have some good data on that from our friends at the University of California, Irvine. Joe Carmichael and colleagues did a large data set review. And typically 15% is what you can expect for all comers. So about 15% of all patients undergoing colorectal cancer surgery need a transfusion. So when you think about a relatively small group of patients who then need colorectal surgery and then need a blood transfusion, it is a pretty small data set overall. So in order to understand what this is all about, I think it's helpful to know, well, who are the Jehovah's Witnesses? For a lot of you, you may never encounter them or very rarely encounter them, except for the weird question on your ABSITE or your board exam, because these are the classic ethics questions, right? And they tell you there's a JW with newly diagnosed cancer who refuses transfusion. He's even at risk of death. And what do? Refuse to operate, transfuse him anyway, ask the spouse. Hopefully you realize document his wishes and operate anyway. So again, who are the witnesses? I'll tell you, here's the way in which I usually see these folks. Just a couple of quick cases to set the tone. I get a call from an outside hospital, an old lady, perforated diverticulitis. She had an emergency Hartman's and then unfortunately sustained all the complications, the big open infected wound, the terrible lungs, the obligatory pressure ulcer, all the stuff. And the outside doctor thinks she now has perhaps an intercutaneous fistula and her hemoglobin by this time is 5. And they always call and they almost always say, well, they're Jehovah's Witness, so this is probably an unsurvivable situation. Like they always find their way to those words. And honestly, as soon as I hear it, I get a little bit triggered. I say, really, you think so? Okay, bring them over. Let's see how it goes. And then we give them our aggressive anemia management protocol, which we'll talk about. She spent a long time in the hospital, much longer in rehab. We waited, we optimized, we cleared her colon, got her hemoglobin back to normal, and successfully closed her stoma, and she was quite happy. Another way in which I often meet Jehovah's Witnesses is this. A young man was scheduled for an elective sigmoid resection for his diverticular disease in the preoperative area. He was really pressured by the anesthesia team to sign a blood consent. And the guy freaked out and literally walked from the other hospital into my clinic, still with his name badge or his wristband on. And, we had a nice conversation. We scheduled him. We took out his colon. Everybody was happy. So, again, who are the Jehovah's Witnesses? So, very brief background on who these folks are. This is a group of Christian folks who this religion started in the United States in Western New York about 150 years ago. Here you see Charles Taze Russell. When I think of a 19th century American religious leader, this is the exact photo that I have in my mind. And so I'm glad that he fits all my biases. Anyway, it is a Christian group, and now there's about 8 or 9 million worldwide, somewhere around 3 million in the USA. And for me, I live in Chicago, and there's about 100,000 in the Chicago area. So overall, it's a small group, but not insignificant. 100,000 folks in the Chicago area, you're going to encounter them. They do follow their own translation of the Bible called the New World Translation. Again, I'm not an expert, but we will talk about a few things that guide their beliefs. Now, transfusion medicine, of course, is not new. This is something that's been going on as long as people have been practicing medicine in any form. This is well documented in ancient literature, as you see here. And as it came into the modern times, first with William Harvey, doing a very detailed description of the anatomy of blood circulation. And then not too long after that, Richard Lower, who did some interesting work with dogs. But then really coming into the modern era, James Bloodnell in 1818 treated successfully the first postpartum bleed with a direct transfusion. Now, it was the horrors of World War II that really accelerated transfusion medicine, in part due to the technology related to vacutainers and blood banks, including the first blood bank in the United States down the street from Loyola at Cook County Hospital, and the horrendous needs of World War II. And then the American Red Cross was instrumental in spreading this technology widespread. So it was only in the 40s after World War II that transfusion medicine started to look like the way in which we know it today. And so it was around that time that the Jehovah's Witness, through their governing body, the Watchtower Society, made a formal declaration and gave guidance to their members about how to manage blood transfusion. And the bottom line is they declared that blood is sacred and holy, and taking blood into their body will result in loss of eternal life. And avoiding transfusions represents a certain obedience to God. Now, you can think this is terrific, and you may be a Jehovah's Witness yourself, and that's great, or you can completely disagree with this. But like with any of our patients, it is helpful to understand why they do what they do, why they believe what they believe, so you can more meaningfully participate in their decision-making process and educate them appropriately as they work through this process. So just let's talk a bit about the origins of the prohibition on blood transfusion. So this comes from a variety of passages in both the Old and New Testament. And in Genesis, in the passage where God is explaining to Noah how to live life after the flood, it is explained, flesh with its soul, its blood, you must not eat. You must never eat any meat that still has the blood in it. Later in Leviticus, as God is commanding Moses regarding the dietary laws, explaining what things to eat and not eat, God explains eat animals with cloven hooves and fish with fins and scales and locusts, all good to eat, but other ground-dwelling animals like weasels and mice and snails don't eat that. Further in Leviticus, life of the flesh is in the blood, don't eat the blood. And on, there's multiple passages that life is in the blood. And so the bottom line is blood is sacred, and you should not use it. Now, some folks who interpret those passages regarding the dietary laws, observant Jews, use that to govern the foods that they eat. And that's where we get these delicacies like kosher lox and kosher corned beef and pastrami sandwiches and all that good stuff that I like to eat. But others took it to mean not just don't eat those things, but don't use those things, don't consume those things, don't internalize those things in any way. And so, in their interpretation, in the modern context, that meant blood transfusion. So not so much eating blood, but using blood in other ways. So that's the origin of don't use blood transfusion. Now, I said it's important to understand the origin of their beliefs because one thing that's important to know is that if observant Jehovah's Witnesses do take blood, they may be disassociated or disfellowshipped because again, from the Bible, it states that God will cut them off from among His people. And so, what you need to realize is that in the most observant JW communities, if somebody accepts blood, they may be ostracized from their community. And it's not just that people sort of frown upon it, but they will be asked to leave their house and their family and support structure will no longer communicate with them. It's a fairly insular community, and so they tend to associate with other JWs. So all their friends and often their employers, their whole support structure are all JWs. And so you can understand that if faced with this decision, it's not just that they're faced with a life-threatening illness that might require transfusion, but it may be that if they agree to this, everybody they know will stop talking to them. And that's obviously a big deal. And so I think it's important to sort of, for us as practitioners, to keep that in mind because very often when they're pressured to take blood, they say, well, it's just blood. I do this all the time. What's the big deal? Well, you know, it's a big deal if that's your religion and your parents will never speak to you again. So just, again, you don't have to agree with it and you can save your own judgments and keep that for yourself, but to understand where some of these folks are coming from. So when considering Jehovah's Witness beliefs, bear in mind this is their religion. And I think like all religions, from just my sort of perspective, people do what they do. And we all practice our religions a little bit differently, right? We all do it just a bit different. And so some JWs are strict adherents to all of those rules, but some don't. And that's why it's important to have private, sometimes conversations, because patients should feel comfortable to let you know what they do and not want to do. The sort of the biggest rule, and we'll get into the details, is that they don't accept the primary blood components. And when having these discussions, it's helpful to know the language that they use of major fractions and minor fractions, and we'll get into that. And also, and I'll repeat this several times because I think it's one of the most important take-home lessons from today, refusal of blood is not refusal of care. This is only about blood. Jehovah's Witnesses want full and aggressive care that you would provide to any other patient, just not blood. But it is limited only to that. Now that leads many people to say, well, what about their own blood, right? That's the obvious question. If you won't take a transfusion, can you auto bank your own? And generally, no. And the reason is that once it leaves the circuit, it becomes not acceptable. But blood that stays in a continuous circuit, like hemodialysis, like heart-lung machine, is generally accepted. And so those things are on the table for most Jehovah's Witnesses. Now, this issue of minor fractions, and again, we'll talk in detail about what that means. There was a change in the year 2000. And again, the Watchtower Society, the governing body, around 2000, put forth a statement saying that it's up to the individual to make their own decision because the individual components of blood, the proteins and such, in the natural setting, move between a mother and fetus. They move across the placenta. And because they're shared in that setting, by their interpretation, that makes it acceptable uh, for adults to receive a transfusion of the minor fractions. So again, you can agree or not, but helpful to understand the rationale. So I like to think of things in sort of these three buckets: the things that are always accepted, I'm sorry, never acceptable, personal decision, or always acceptable. And we'll just run through them because you know these things, but I think it is helpful to remind ourselves, especially of that middle group. So the first group, never acceptable, and that's easy. Whole blood, red cells, white cells, platelets, plasma. Observant Jehovah's Witnesses will never accept these. Now, again, keep in mind, sometimes when faced with a life-threatening illness, they will choose to do it. But the usual beliefs and recommendations are no blood, plasma, or platelets. Now, the stuff that falls into the minor fractions or personal choice bucket, let's just talk about some of those because some of these are important to us doing colon and rectal surgery, especially the minor fractions of plasma, because that's where we get clotting factors and that's where we get albumin. Now, most albumin that you transfuse in clinical practice is pooled human albumin. That comes from donated blood. Synthetic albumin or common albumin is a thing, but that's not what we usually give. That's mostly used for research purposes and drug development. More on that later. Also, are stimulating factors like erythropoietin is the most common one. Now, the erythropoietin or epogen that we use in clinical practice is synthetic or recombinant, but it is manufactured in such a way that it contains small amounts of human albumin. And it's right on the box as a warning because it is human protein. Now, patients, again, have the right to choose what they want to accept or not, but it's incumbent on us to counsel them appropriately. So the epogen is recombinant, but there is a small amount of human protein in it. And again, as mentioned, all the clotting factors, especially things like Kcentra, that comes from human proteins. Not used all that often, but you have to know what's in these things if you're going to ask patients to sign off consent or not. Thrombin as well. Thrombin comes both bovine, although that was largely phased out after mad cow disease concerns, or human is available more commonly for clinical use. And same with fibrin glue, which makes use of human thrombin. And then, as I mentioned briefly, techniques that keep blood in continuity, like cell salvage or cell saver, or hemodialysis or cardiopulmonary bypass if you do that kind of stuff. But cell salvage does keep blood in continuity. Now, in colon and rectal surgery, we rarely use it because things like contaminated field or cancer cases, you don't usually want to re-inject stool or cancer cells back into the patient's circulation. So in some cases, it may be appropriate, but generally not helpful for the kind of things that we do. Now, the things that are always acceptable, of course, are iron, and that comes in a variety of flavors, both oral and IV. Vitamins to help stimulate red cell production, and then clot stabilizing agents like TXA and aminocaproic acid, things we don't often use, more commonly used by orthopedic surgeons, cardiac surgeons, but helpful to keep in mind when you're doing these cases because they will stabilize the clots. And then the topical agents, which we do use somewhat regularly, but important to understand what they are. Surgicel is oxidized cellulose, entirely synthetic, and that comes in a bunch of different formats. You can choose whichever one you like. I personally like the Surgicel powder because you can spray it across the whole field, and when you have just that little bit of oozing from everywhere, you can nicely cover the whole field, whether you're doing open or minimally invasive surgery. Gel foam, and that's gelatin made from pigs. Gelatin mostly comes from ground up pigs, which may be unacceptable to some other kinds of patients, but Jehovah's Witnesses are perfectly happy to accept that. And then epinephrine, don't forget that as an adjunct to achieving good hemostasis, either epinephrine by itself or more commonly with local anesthetic with epinephrine, which you can inject near some bleeding or spray topically in a bleeding surface. I'm not going to spend a lot of time on artificial blood or hemoglobin-bound oxygen carriers because there are currently none FDA approved. There's a whole bunch in various degrees of trial, but if Jehovah's Witnesses ask you, can you give me the fake blood? At the current time, there are none available. So unless you're a part of a clinical trial or at a specialty center, you cannot use that. Okay, so at this point, you're saying, well, what's the big deal? Fine, you told me don't give them blood and give them lots of Surgicel. I think I got it. But it is a big deal for these patients from a practical standpoint, because I will tell you, they continue to have a hard time finding places to get care. And so if you have a nasty rectal cancer or an active GI bleed and you want to get care without blood, it is a big deal to understand who you can turn to. Now, most of the reluctance has to do with refusal to treat, primarily for fear of lawsuits. And this is on the part of the hospitals and doctors. So let's just talk about that briefly. Again, I cannot emphasize enough, refusal of blood is not refusal of care. It is not DNR, DNI. It is not palliative care. It is not physician-assisted suicide. And you may think I'm being dramatic, but when I receive these calls from the outside physicians, these are the kinds of things that the community folks are saying, and not just small town community hospitals, large university centers here in Chicago. They say that the patient is asking for physician-assisted suicide to undergo an operation to take out their bleeding cancer. I mean, it's peculiar, but it's viewed in that way by many physicians. But I'd like to try and explain to you it is not. It's none of these things. It's just a refusal of blood. All of the concerns about taking care of these patients and being sued should be alleviated by the fact that all of the law lies in favor of the doctor and the hospital. And this comes from a series of things, including the Patient Self-Determination Act, establishing that patients have the right to decline some or all aspects of care, even if it results in a poor outcome. And I tell you, the JWs are extremely well educated about their legal rights. They're all about this. They talk about it, their leaders educate them on it, and they're very much in touch with these things. This has been litigated in a variety of states, including here in Illinois, where I practice. And I'll just share with you one example of how this all goes. In the 60s, at a nearby hospital, an elderly lady had a bleeding ulcer when that was still a thing. And everybody knew, including her doctors, knew she was a Jehovah's Witness and refused blood. And she was going to die. And of course, they gave her blood, knowing all this. It was litigated all the way to the Illinois Supreme Court, at which time they ruled, and this was kind of a sign of the times, the language they use. But the Illinois Supreme Court said, even if they considered the appellant's belief unwise, foolish, or ridiculous, accepting medical treatment forbidden by the religion, such action cannot be constitutionally countenanced. So they were basically saying, if the patient says it's her religion, you have to respect that. You cannot transfuse them against their will. Now, that was in Illinois, and you may be wondering, well, I'm not in Illinois. Has the Supreme Court of the United States ruled on that? The JWs have been to the Supreme Court actually a whole bunch of times for a variety of things that you may be familiar with, but not be realized it's from the JWs. In the 40s, they went to the Supreme Court because they don't like to say the Pledge of Allegiance to the flag. They think that goes against their religion, and so they went to the Supreme Court and they won that case. And if you don't want to say the pledge in school, you do not have to. They also went to the Supreme Court because they like to knock on doors and try and convert you to the religion and give you brochures and literature. You may have encountered that in your own home. And they went to the Supreme Court who said, yeah, they do have the right to knock on your door and offer you pamphlets. This has mostly been replaced, just as a side note, the door knocking has been replaced by carting. They like to stand at train stations and bus terminals and shopping centers and airports, especially, and give out literature. You may have seen these guys when you travel, and that's largely replaced the door knocking. But there are no Supreme Court decisions on blood transfusion in the United States, just so you know. As a side note, my son last year graduated college in St. Louis, and every day in front of his apartment, they were carting. They would set up shop right in front. And then he traveled around the world a little bit and saw the same setup in all kinds of cities all around the world. He actually accused me of dispatching the guys to keep an eye on him as he was traveling around the world. I said, no, no, they're just there already. They just have the same carts wherever you go. I did not send my guys to keep an eye on you. Uh, although the Supreme Court in the United States has not ruled on this, the European Court of Human Rights, which is the European body that handles such things, um, just recently, 2 years ago, did rule on this. A woman had a hysterectomy for fibroids. She was transfused against her will without consent, and there was a unanimous ruling for the patient, confirming that it is the absolute right of patients to decline some aspects of their care. And so I would like to again emphasize all the legal protection actually lies in favor of the doctors and hospitals, but the opposite is certainly true. If you transfuse them against their will, you will be in significant trouble, not just as a matter of malpractice, but in the United States, you can be sued for assault. It becomes a criminal offense. But if you care for them without transfusion and they have a bad outcome, including death, you cannot be held liable just for that aspect of their care. It is not refusal of care. Okay, so let's through the surgery is never truly bloodless, but this is the nomenclature Jehovah's Witnesses use. And again, I think important to understand the way in which they talk about things because they may show up and say, I'm looking for a bloodless surgery. Don't laugh. Don't say that's impossible. That's just the terminology, the nomenclature that they use um, for this kind of care. Now, the way in which many Jehovah's Witnesses seek care is through a network of hospital liaisons. There's thousands of volunteers in many countries around the world who help connect Jehovah's Witnesses with doctors and facilities that will treat them with respect to their wishes. And basically, these guys, when they're sick or in the hospital, they call the liaisons who then call individual doctors to connect the two. What's important to remember is that hospital liaisons, the HLC members, are not powers of attorney. They're not next of kin. So they don't have automatic access to their private information. So it's great that they connect them to people who can care for them in a way in which they want to be cared for. But if you talk to these folks, be cautious about revealing private information. Again, they don't have power of attorney, unless they do have specific power of attorney, but generally they don't. So just don't reveal too much information. And usually I'll tell them, hey, we've received your member in transfer. We're plugging them with all the appropriate care and, they're on the right path. But don't tell them what their latest labs are or they need surgery or any of that kind of stuff. Now, bloodless medicine and surgery is really not just an individual thing, but a series of techniques. In a lot of ways, reminds me of enhanced recovery, right? That enhanced recovery, and this is what we do at Loyola, and I'm sure you all have similar protocols. It's not one thing. It's really a whole perspective on perioperative care. And so I similarly view our Jehovah's Witness bloodless medicine as a series of things that we do in the entire perioperative period. And I'm not going to discuss all these, but just I'll highlight a few of them. All of this starts before patients get to the operating room by understanding their desires. And every Jehovah's Witness, and I don't mean to generalize, but really every one of them will carry on their person some form of this card. In their wallet, in their purse, somewhere, they always carry something telling practitioners that they do not want blood. Now, the card basically is an alert that they're Jehovah's Witness, but it's not detailed enough. The card is not going to talk about things like cryoprecipitate. So use that as a starting point for a more detailed conversation. And you may have at your hospital, like we do, some electronic tools like refusal or limitation of blood that they can sign. But again, those don't usually have the same level of detail. So we've created within our Epic world a simple checklist which reminds both the practitioners and the patients what's recombinant, what's human, and basically I just buzz through this. And so I can easily document, do you take erythropoietin, do you take, albumin, and you just go through with a yes or no checklist. And although it's sometimes difficult to have these conversations, like if you're signing somebody up for an elective hemorrhoidectomy, you don't start talking about risk of death from bleeding, right? Because nobody's going to sign that consent. Nobody wants to sign up for that. But don't be afraid because this population, not only are they comfortable having these conversations, they want to. They go to you, they come to centers of excellence specifically to have that conversation. they're not afraid of it. They will welcome the opportunity to have the conversation about transfusion and risk of death. And they want to tell somebody, listen, if it comes to it, I would rather die than receive blood, and I'm comfortable with that, and my family knows it, and that's what I believe, and it's fine. Don't be afraid to have this, even if it's not part of your usual informed consent process. Now, before surgery, we often will have to optimize these patients, and that mostly revolves around aggressive anemia management. Everybody gets B12, folate, vitamin K if necessary, and iron. Whether you use iron or IV is sort of dependent on your preference and also the severity of their anemia. Patients who are quite anemic, we give them these massive doses of erythropoietin, 4,000 units daily until their hemoglobin gets above 7, and then we go to weekly. But again, it depends on the degree of anemia and the urgency of their operation. Just those things, iron and epogen, have been demonstrated to work. Here's a nice meta-analysis, not in Jehovah's Witnesses necessarily, but in patients who are anemic, and you can reduce the need for transfusion just with that alone, iron and epogen. Also, of course, important part of repleting somebody's anemia is nutrition. So in patients you might not otherwise think about a nutritional intervention, these are folks you need to intervene on because if they're malnourished or barely nourished, they're not going to make blood fast enough. And this, of course, takes time. And so you have to emphasize supplements. You know, it's fine to tell them eat steak, eat a high protein diet, but you need to give them supplements because you don't have the luxury of time in a lot of these patients. And that brings up the whole issue of timing. Sometimes you go fast, sometimes you go slow, and that decision is different in Jehovah's Witness patients, meaning that in the fast patients, you have to go really fast. So if somebody's bleeding, somebody comes with a GI bleed, you might otherwise say, let's trend their anemia, let's see how they do overnight, let's give them a day or two. You don't have that luxury because if they come and their hemoglobin's 5 or 4, and you say, let's observe, and they rebleed, they're going to die, right? That's it. They don't have the luxury of seeing how things go. So if somebody has an emergent problem, start them on an aggressive protocol immediately and round up all the consultants, whether that's GI for a scope or IR for embolization or hematology, everybody get them on board quickly. Now, in the slow patients, you want to go really slow. So if somebody comes with a cancer and they're anemic, as much as they may be anxious and want to get on the schedule tomorrow, as much as the family's freaking out, and as much as you want to, fill a gap in your schedule, you need to slow down and address their anemia first for a lot of reasons, because repleting their anemia will give you a better outcome, take time to optimize their nutrition, and emphasize to them that doing a repleting their anemia may allow you to do a one-stage operation rather than a two-stage and avoid a stoma. And patients are usually on board for that. Significant anemia is a major risk factor for anastomotic leak. We don't usually think that much about that because we feel pretty comfortable to transfuse our patients, but if you cannot or will not, it is a risk for leak. And if that's the case, and if you're forced to do it, you may need to tell them, listen, you need to get a two-stage, three-stage operation, whatever, because of your anemia by itself. And again, that's not something we usually do. But I would caution against an anastomosis in somebody whose hemoglobin is 5 or 4 or 3, and just give them a stoma, and that's okay. Let them know they'll do fine with it, and you can close it later once you've corrected all of that. So a quick case to drive that point home. Here's a gentleman who was transferred in. He was bleeding. The outside hospital would not colonoscope him, which is very often the case because his hemoglobin was 4, and they were afraid to scope him. I usually talk to these guys on the phone and, I sort of say, well, what are you going to, you're just going to watch them bleed to death. What's your plan? Well, nobody, so fine. We bring them over, we get our guys to scope them. They find a tumor, but it was not currently bleeding. And so we put him on our protocol. We aggressively supplement his anemia. And in 6 weeks, when his hemoglobin is normal or at a safe, a level you feel safe doing an elective operation for me, and we took out his cancer, one-stage operation, everybody's happy. Here's another one that illustrates another challenge of managing these patients. This gentleman had a massive GI bleed witnessed in the hospital. They saw him bleeding. His hemoglobin got to 5, and they wanted to transfer him over. So we accept him. This was early in my experience, and so we got the hematology folks on board. And what does hematology do? They do what they always do. They recommend getting a slew of labs retic count, thyroid studies, B12 levels, right? Because that's what consultants, especially hematologists, do. To that, you can give them a polite no way. When somebody has a witness GI bleed in the hospital, he didn't also become hypothyroid right at that same time. That is not why he's anemic. Don't waste a vacutainer of blood trying to understand if he's hypothyroid. The answer is no, or I don't care. He might be, but we'll deal with that later. He had a GI bleed. Stop wasting blood. It's one of the most challenging things we do. Now, moving on to intraoperative management. As you all know, MIS surgery comes in a variety of flavors. You can do whatever you like, whatever you're good at, but definitely do minimally invasive surgery. In our practice, probably like most of yours, we focus on robotics. And there's lots of data demonstrating reduced bleeding for robotic surgery. Now, I bring this up because, in part, it's true, there is less bleeding, but in part, you may be familiar with the literature like this, which shows that the reduced blood loss is like 100 cc's or whatever. So for most patients, clinically, that's not going to make a difference. But this is important, I think, in two settings. Number one, if your hemoglobin is 5, 100 cc's is important, okay? Every drop counts. It really is. And so keep that in mind. And number two, the Jehovah's Witness community is very familiar with this literature, and they don't share the same perspective of, well, 100 cc is not that big a deal. All they see are the concluding statements, and they know robotic surgery causes less bleeding, so they're actively seeking it out. And I don't say that as an endorsement of robots specifically, but minimally invasive techniques. And so this is a crowd that looks for minimally invasive surgery in both the elective and the urgent setting because they know it's associated with reduced blood loss. So keep that in mind. Also, on the intraoperative management, things like Cell Saver, if you can, it's a good thing to use. You have to schedule that generally ahead of time to get the technicians and all that. Most of our cases they're not good candidates. Something that I think is important to remember, having an arterial line, I don't know if your anesthesia team likes to do that frequently, liberally, whenever. Sometimes they say, well, the arms are tucked, I need an A line. That's all good and fine. But having an A line is not an indication for labs. You will find this to be true that having access to an A line tends to result in way more labs. And the anesthesia team will say things like, let's get a baseline ABG and see where we're at. But that's not really a thing in a stable patient with normal lungs. You don't need to do that. Most patients don't have A lines, right? You don't need to draw an ABG to see that when they're saturating 99%, everything's okay as verified by a blood gas. Don't waste blood. In most patients, not a big deal. But again, when their hemoglobin is 6 and 5, don't send labs just because you have easy access. Get labs if and only if you really need them. Concentrate on things that promote good hemostasis, patient warming, fluid warming, stuff we all know and we often do, but really pay good attention to those details. Use the topical hemostatics we talked about liberally or routinely. Use TXA. It's not something we do all the time, but I will tell you when I operate on Jehovah's Witnesses and do a big abdominal case, I use it routinely, every case. Just give 1 gram right at the beginning of the case. And then post-op, do all the same stuff. Aggressively manage their anemia, give them iron, give them vitamins, give them epogen until their hemoglobin is safe. Aggressive nutrition. Consider TPN in somebody who can eat but isn't eating very much. They're not going to make more blood if they don't have adequate nutrition. And I'll say the hardest thing to do in the hospital is reduce labs. Think about every patient getting every lab every day by every consultant. Resist the temptation to order labs. And if you really need them, use a pediatric tube. These tubes require 50% the volume of adult tubes. It makes you wonder, why don't we always get it? You should. There's interesting literature on this. This is a great paper from several years ago, but they have a great quote. In today's medicine, bloodletting continues unabated. Today we call it lab work. It's a real thing. Patients sometimes cannot make blood as fast as we withdraw it. Now, in the post-op setting, when patients rebleed, you have to be aggressive. Again, don't just trend it, don't just follow it. If patients are rebleeding post-operatively, get a colonoscopy right away, get embolization. You have to act. Don't just watch them. So in our hospital, we sort of tied this all together as an order set, which we built into Epic. I'm happy to share that if anybody's interested. Um, there is data from centers, bloodless centers that show that patients who are anemic tend to do worse. That's true, but they do about the same as patients who are not Jehovah's Witnesses. So even if you give them blood, it doesn't necessarily turn around all the badness of their anemia. And as much as I criticize the literature at the beginning of this, there are some good things in the literature. And here's just one example of cardiac patients at Cleveland Clinic. Now, they, of course, we all know, do huge volumes of everything. But in several hundred JWs undergoing cardiac surgery, they demonstrated comparable, actually superior outcomes, meaning less MIs, less reoperations. And it's probably because in these patients, you're paying more attention to managing their anemia and excellent hemostasis. Like, you do all the little things, and that does make a difference. Outcomes are sort of all over the place. Again, the literature is quite variable and not a great source of definitive information. But the good news is there is plenty of room for research and publishing opportunities if you're interested. Now, there are lots of resources available to help you. The Jehovah's Witnesses themselves maintain an interesting website that has a lot of religious stuff, but has a lot of things for providers, because they like to direct their doctors to their own website and say, hey, there's a bunch of papers and guidelines and things. So you can look on jw.org. Like everything about the internet, there's an evil flip side. jwfax.com, which you can see makes use of the same font and color scheme. This is a website that explains how horrible the JW folks are and how they're torturing their own people and all that. Again, I'm not saying that to judge how good or bad these people are. Just be cautious of the websites you look at. And that's always, a good rule of the internet. There are professional societies, and here you see a couple examples, like the Society for the Advancement of Patient Blood Management. These are regular, multidisciplinary professional societies that have meetings and publications like Askers and everything else, and talk about strategies to reduce the need of transfusion. Even our College of Surgeons, probably our most famous professional society, has a nice position paper. We're not going to review it, but I will point out that their concluding statement is bloodless surgery is good surgery. Taking care of patients in this way is not just sort of for the niche practice of JW care. Reducing blood transfusions is good for all of our patients. And so you should try and focus on repleting anemia and reducing the cost and risk of blood transfusion for all of our patients. And you can look up the ACS white paper on that if you're interested. I mentioned that there are specialty centers that do this well, some of which are big name centers. Some of you on the call might be at some of these places like Duke and Hopkins. Some are smaller community hospitals that just do a great job with this, and their websites have a lot of good information. I'm here in Chicago. Strangely, there are none in Chicago. There's a bunch around the Midwest, but there's no centers. I've been moving Loyola towards creating a center, and I think we're on the brink of finally doing it. For a number of years, I've been sort of trying to manage a bloodless center, mostly by way of my own personal cell phone, and they just call me and text me and ask me to plug them in with other providers. We finally established a dedicated phone line. Somebody in the marketing department was trying to be, I think, a little bit too cute and made the phone number JWMD, but whatever, we do have a phone number. As I mentioned, we have some dot phrases in our Epic world. We have some flags to signify that they refuse. We've instituted the HemoQ machine on some of our units. This is the finger stick hemoglobin machine. It's just like an AccuCheck, just a single drop of blood. So rather than wasting a full tube for a CBC, all you need is 0.1 cc's. And you can order this on the internet. It's a couple of $100. It's not like a huge investment. And this is very helpful to have both in the clinic or in the hospital or in the ICU for that matter, if you really want to trend patients. Again, it makes you think, like, wouldn't this be nice for all kinds of trauma patients? Yeah, it would. You should do this for a lot of patients. In our hospital, we had to work with, some of our colleagues, like in our ER, to expedite the throughput. They draw all the panels of labs before anybody sees them. And I had to shut that down for our JWs. That's a lot of blood. And they would get all those tubes and then say, oh, sir, did you know your hemoglobin's 3? No, they didn't, but now it's 2. Thanks. I appreciate that. I have community events on Zoom just like this, and these folks are super motivated. The minute I start this, it fills up to 500. That's the maximum on the cheapy license that Loyola buys. Probably it'd be thousands if we had the good license, but they're very motivated to learn about what you're doing. So in conclusion, I'll share some lessons learned in caring for this community. Keep in mind, people do what they do. This is their religion. We all practice a little bit differently. So talk to the patients and get their individual preferences. Do not accept the so-called unsurvivable situation. It's rarely unsurvivable. You can help these folks. It generally goes fine. You just have to pay attention to all the details of the protocol. And I think doing nothing is not really a good answer. Just watching someone bleed to death because you're afraid to care for them is not okay. The bottom line is all the protections lie in your favor. And if you really don't want to care for them, that's okay. That's your choice and decision, but send them to somebody who will. And engage your colleagues, get everybody on the team involved, but manage the consultants carefully. Don't let them order a million labs unnecessarily. And work with the hospital liaisons. They are very helpful, but do maintain your privacy, the patient's privacy. Don't get stuck in your routines. Don't order every lab every day on every patient. You don't need to know somebody's phosphorus when they're 10 days post-op on a general diet. Justify every single lab that you order. Patients appreciate an open, honest discussion about transfusion and the real risks of blood and surgery. Patients who need to go fast, go really fast. Patients who need to go slow, go really slow. It's hard to cancel or delay a case, but do it. Manage their anemia, invest the time. They'll appreciate an investment of that time to get a better outcome. And then be familiar with the things that we use frequently, but sometimes we take for granted, and just refamiliarize yourself with what's human, what's recombinant. What do we have in our OR? What kind of hemostatic agents are available to me? And like the College of Surgeons says, apply this experience to all patients because bloodless surgery is good surgery. And again, refusal of blood is not refusal of care. And I'll wrap it up by sharing I've taken care of somewhere around 180 patients now, and it's been quite rewarding. These patients are the most grateful and appreciative of all the patients I care for. They don't expect miracles. They don't expect a good outcome every time. They just want to undergo care with respect to their beliefs. And they're so appreciative that I'll tell you, they're constantly offering you all the sort of little perks that you get. They always want to offer you, tickets to sporting events. At Christmas time, they offer gifts, not like the weird fruit cakes that some patients bring at Christmas time, like the really good holiday baskets, like the really luxurious stuff. You should know that Jehovah's Witnesses don't celebrate holidays. So every Christmas when they send me their super luxurious baskets, it's terrific because I don't celebrate Christmas. They don't celebrate. Nobody celebrates Christmas, but I'm happy to eat their delicious baskets. One of the guys in Chicago has a nice boat downtown, and they're constantly inviting me to go hang out on their boat. Me and boats don't really get along too well, so I usually don't take them up on that. And I will say it's easy when we're busy and super busy, and in corporate medicine, we become very jaded. Loyola, as a Jesuit hospital, likes to have these kind of advertising campaigns. We treat the human spirit, body and soul, all that kind of stuff. It's easy to sort of poke fun at that. But caring for Jehovah's Witnesses reminds you that there are patients where this kind of stuff is important, perhaps their most important aspect of their care. And when you do provide care with respect to their beliefs, to their desires, to their human spirit, they appreciate it beyond belief. And it is rewarding and refreshing in a different way on our side when you can provide a kind of care that means so much to them. So thank you for your attention. We do have a few minutes. If you have any questions, I'm more than happy to answer them as best I can.
Thank you, Dr. Singh. That was a really excellent talk, very comprehensive and very specific, tips on what we can do that are easy and definitely doable. We do have a question in the chat. How do you manage the DVT prophylaxis pre-op in hospital and for home, especially for the cancer patients?
Yeah, excellent question, and that comes up commonly. Interestingly, the recommendations for chemoprophylaxis, heparin, are that you should start it within 24 hours of surgery. We generally give it right before surgery because that makes the most sense. But it's all about managing the risk. So if I'm doing a totally elective case and the hemoglobin is 14, I'll give them heparin on the table as you normally would. I give heparin, not Lovenox, because shorter acting. But if I'm worried about a patient or they're already pretty anemic, I will not give it preoperatively. SCDs for sure, but I'll hold the heparin. If the case goes great and they're dry and I didn't lose a lot of blood, I'll give it immediately post-op, like on the table or in the PACU. But I will sort of assess the very specific risk of bleeding and anemia when making that decision.
Do you routinely, let's just say the case goes fine, and the patient has, you know, that maybe their hemoglobin's 10 or something like that. Would you send them home on Lovenox like 30 days or do you
Right.
usually not?
So, yeah, sorry. Again, based on the risk. So if the case goes fine,
Mhm.
I'm not worried about bleeding and their hemoglobin is normal, yes, I will send them home on 30 days of Lovenox, as is our standard practice. If it's lower than that, I'm a little worried about it, or they're very anemic, then I'll hold it. And again, you just explain to them
The
you need
risks.
to walk every day, but you may have an increased risk. And they're fine about that. They're all about managing the risk mitigation in the context of avoiding blood.
Mhm. Are there any other common issues in the care for Jehovah's Witnesses apart from the blood-related concerns, or is it, in your experience, it's very similar?
It's just blood. They accept vaccines. That comes up from time to time. They're not Christian Scientists who don't accept most aspects of modern medical care. They accept everything else. I will say there are some unique ethical and legal issues to care for pediatric patients, which I specifically stayed away from because that's a whole other deal, and I don't usually care for minors anyway. But that can be a whole separate issue that would require involvement of hospital attorneys, ethicists, pediatricians, etc.
Got it. Um, what do you do, or how do you manage if there are disagreements between the patient and family? I'm not sure if that's ever come up. How do you navigate those issues? What if a patient tells you, I want a
Yeah.
blood transfusion, but please don't tell my family?
Right. So that does come up from time to time. I'll say not commonly, but on occasion. So when they come in with the family and you have the conversation that, yeah, I refuse it, I'll sign away everything. But then privately, sometimes at night, when faced with a risk of death, they will say, you know what, I want the blood. But because of the social dynamic, they will say, don't tell my family. Now, in that situation, you have to, of course, honor the patient unless they have a written power of attorney, but you have to honor their wishes. I tell them, listen, if we're going to hang blood, I'm going to hang it. And I can't get caught in sort of the shenanigans of, well, transfuse me after midnight when I have no visitors or during this time. But no, I say to them, I'll transfuse you, but you need to manage your family. So if you want visitors, fine. If you don't want visitors, you tell the family no visitors. But I don't want to get sucked too far down the rabbit hole. I will accept blood between midnight and 4 a.m., but not other time. Either you're going to get it or you're not, and they need to manage all that other stuff. But it does come up from time to time.
Um, And then you had mentioned that most of the Jehovah's Witnesses do carry a card. Have you ever been in a situation that was, I guess, a little bit more emergent? I assume it doesn't happen in colorectal surgery as often as like trauma, where you do something that is kind of against their wishes out because we just didn't have the information and that you have to manage it kind of the back end.
Yeah, it doesn't usually come up in our specialty. It's not common we'll see an obtunded patient or whatever. It's more of a trauma issue. But I guess, sometimes patients are demented and, not capable or competent to make decisions, or they become unstable during their hospitalization. So those things can come up. And so for those reasons, like with any patients, you want to document their preferences as early in their care as you can, even before you know if they need surgery or not. You want to document it because should they become incapable of making those decisions, get it in their chart. Now, if it happens, or in the trauma situation, I will just tell you that if they come in and you transfuse them because you didn't know that they were a witness, it's fine. They're not going to be mad, and the community will not ostracize them if they receive blood but did not make that decision themselves. Uh, it's really only an issue of making that decision. That's what it comes down to. So as you all know, that if a trauma patient or an obtunded patient comes in, you give them full and aggressive care until you know otherwise. If they wake up or the spouse or next of kin comes in and says, hey, they're a witness and here's their documentation, from that point forward, of course, follow their wishes. But if you do it before you know, it's not really an issue because you didn't violate, their wishes to the best of your knowledge.
And then the last question, can you tell us a little bit more about your techniques for hemostasis and hemostatic agents? Are there anything specific like get rebleeder on your way in?
Yeah, it's really the stuff that you already know. It's not like a secret when it comes to intraoperative management. Go slow, use energy for most of your dissection, whether it's Bovie or N-seal or ligature or robotic vessel sealer. I mean, use the stuff you like and you're familiar with. Take your time, seal everything, and use the topical hemostatics liberally, like routinely, like all the time. And yeah, does it take you a few extra minutes in the operating room? Of course it does, but that's fine. I mean, you're not talking about a significant increase in time, but it certainly will help minimize the amount of rebleeding or that hemoglobin drift. We commonly see a gram or two. Again, that's fine if you start at 14, but if you start at 6, it may be a problem. So just take your time, be patient, use energy devices and the topical stuff. For most of these cases, I give a gram of TXA routinely. It's not prothrombotic, it's just a clot stabilizing agent. So it's not going to give everybody DVTs. It's just going to help stabilize the clots. And those are kind of the main things. There's no secret to that. It's just using all the things you learn in your general surgery and in your fellowship, just paying very close attention to all the meticulous details.
And last question, are there any people for whom your typical anemia management, like medical management with supplementation, does not work, or you're not supposed to do any of those things in certain populations of people?
So sometimes it doesn't work, and that's when I'll get the hematology folks involved. As a general rule, if you put them on the aggressive protocol, you can expect their hemoglobin to increase about a gram per week. In healthy patients, it goes faster than that, but in your usual older cancer patient, about a gram per week. So if somebody comes in at 6 and you tell them, I would like to get you to 10 or 12, you can expect 4 to 6 weeks delay till operation. If they're not responding, then get hematology because they may have additional issues. And it's possible they have a slowly bleeding cecal cancer and some other problem, and I feel like we're not often not well equipped to help sort out the medical causes of anemia, other than GI bleeding and nutrition and those kind of things. So that's when I'll get our colleagues involved in that.
Great. I think that's all of our questions. Really want to thank you for your time on this Sunday evening. I'm sure everyone learned a lot. Thank you.
Great. Hope you enjoyed it. And feel free to send me an email at, you can find me at Loyola. I'm happy to share the slides or our protocol or any of that kind of stuff.
Great. Thanks.
Have a good night, everybody.